Welcome to the deep dive. Whether you are a urogynecologist prepping for, a complex reconstruction, or maybe a pulmonologist interested in how the body systems talk to each other, or honestly just a listener with this insatiable curiosity about the human body, you're definitely in the right place today.
Yeah, absolutely. It's one of those topics that really perfectly shows how everything is connected. Like no system in your body actually works in isolation.
Right. Because today we are digging into a pretty massive stack of sources. I mean, we've got everything from the Journal of Urology to these big Cochrane reviews and global clinical guidelines. And our mission for today is to explore this really fascinating medical crossover.
It really is fascinating. It's this idea of how a lung problem, specifically chronic obstructive pulmonary disease or COPD, or even just like a really bad chronic cough, how that can actively sabotage stress, urinary incontinence surgery.
Exactly. Like we're looking at this biomechanical mystery, right? How does a cough in your chest literally undo a meticulously tied surgical suture way down in your pelvis?
Yeah, and it really highlights how, keeping medicine in these strict silos like separating pulmonology completely from pelvic reconstructive surgery, it kind of misses the bigger picture because your body functions as this continuous pressurized column.
A pressurized column. I like that.
Right. So a respiratory event like a cough is inevitably a pelvic event too.
Okay, so let's unpack this. Before we even get into how a cough, ruins a surgical fix, we have to talk about how the cough breaks the body's natural anatomy in the first place, right? To cause the stress, urinary incontinence, or SUI.
Exactly. You can't understand the failure of the surgery without understanding the baseline failure of the anatomy. And our sources point straight to Petros's integral theory for this.
Right, the integral theory. So the analogy that always helps me visualize this, think of the female pelvic floor like this really specialized trampoline, and the muscles and the connective tissues, they're basically the springs holding the whole thing taut.
That's a great way to picture it.
Yeah, and a cough is essentially like dropping a bowling ball onto that trampoline from like the roof of a house.
Basically, yes.
Yeah.
And what Petros's theory explains is that SUI isn't just, it's not just a muscle issue. Like it's not just a weak sphincter. It is fundamentally a loss of connective tissue integrity.
Right.
The sources specifically talk about the pubourethral ligament and the endopelvic fascia. Normally, these act as this firm backboard or like a hammock.
A hammock. Yeah, that's the word the literature uses a lot.
Exactly. And when you sneeze or lift something heavy, your intra-abdominal pressure spikes. The urethra is supported by that hammock, so your pelvic floor muscles just compress the urethra right against it to stop any leaks.
So the pressure inside the bladder goes up, but because it's being squeezed against that backboard, the urethral closing pressure keeps up and you stay continent.
Right. But then, you introduce a chronic cough, like the really severe hacking fits you see in COPD or with heavy smokers.
Bowling ball on the trampoline.
Exactly. The mechanical load changes completely. A chronic cough creates these massive repeated spikes in intra-abdominal pressure. We're talking about intense rotational vector forces just driving down into the vaginal wall and those connective tissues.
And tissue can only stretch so much, right? I mean, eventually it just gives up.
Yeah, basically, the technical term is plastic deformation. The tissue literally undergoes creep. The collagen fibers stretch out, you get all these micro tears, and the hammock becomes permanently elongated and loose.
So the trampoline springs are shot.
Yep, the backboard is gone. So the next time that patient coughs, the urethra has nothing firm to compress against. The pressure in the bladder easily overcomes the resistance, and you get involuntary leakage. The cough physically sheared the anatomy.
Wow. Okay, so the native anatomy is broken. That brings us to the surgery. The surgeon goes in to build a new fix, right? They put in a synthetic midurethral sling, or maybe they do a culpa suspension with permanent sutures.
Right, they're basically trying to synthetically recreate that firm backboard.
But this is what I don't get, and I really want to push back on this a bit, based on the sources. If a surgeon is using these incredibly strong materials, like heavy-duty polypropylene mesh or heavy-gauge permanent sutures, how does a simple cough undo that? It's not like the patient is coughing hard enough to snap a surgical-grade plastic mesh.
Well, what's fascinating here is that it's not the material that fails. It's the tissue holding the material.
Oh, interesting.
Yeah, the literature calls this suture disruption or pull-through.
Hmm.
You have to remember, when the surgeon finishes up, that synthetic material is relying 100% on the patient's own native fascia to hold it in place while it heals.
Right, because it has to integrate.
Exactly. The body has to move from the inflammatory phase into the proliferative phase.
Hmm.
Fibroblasts have to lay down new collagen to lock that mesh in. and that takes weeks.
So it's basically a race between how fast the patient can grow scar tissue and the mechanical stress they put on it every day.
And if they have COPD, they are violently yanking on that fresh repair every single day. Think of the mooring line analogy.
Oh, right, yeah. So if you tie a boat to a dock with a heavy synthetic rope, the rope is strong, the knot is perfect. But if a massive storm rolls in and the waves start violently heaving the boat around, the line doesn't snap. The metal cleat gets ripped right out of the wooden dock.
That is exactly what happens in the pelvis. The suture acts like a cheese wire. The patient coughs, the pressure spikes, and the suture literally just slices right through the fragile healing tissue because it can't handle the localized stress.
The cheese wire effect, that sounds incredibly painful, and just mechanically it makes so much sense. But the sources point out it's not just a mechanical problem, right? Like these specific patients, COPD, asthma, smokers, they also have a massive biological deficit.
Oh, absolutely. They have terrible tissue healing to begin with. Smoking causes vasoconstriction and chronic hypoxemia. Basically, their tissues are starved of oxygen.
So they aren't even producing good scar tissue.
No, they aren't. They have suppressed fibroblast activity, and the collagen they do make is structurally inferior. So they are generating the absolute highest mechanical stress.
While relying on the weakest possible biological anchors, that is a terrible combination.
It really is. And the historical data back this up entirely. The older procedures, like the STEMI procedure, failed all the time in patients with significant chest disease. But it's not just the old stuff. There's this study from Morgan in 1995 that is just wild to read.
Yes. The Morgan study, I wanted to bring this up because the numbers are staggering. They looked at 88 women who got a cubovaginal sling. And in that whole group, only about 9% actually had diagnosed pulmonary conditions. Like a tiny minority.
Right, just a small fraction of the group.
But then they looked at the persistent failures, the surgeries that just completely fail to fix the incontinence. Out of those absolute failures, 50% of them, half, were the patients with asthma or bronchitis.
Yeah, when a group that makes up less than a tenth of the total study accounts for half of the absolute failures, you're looking at a massive red flag. Chronic respiratory pathology is a glaring, independent risk factor.
But the text does note a bit of a confounder there, right? I mean, out of the 4 persistent failures in that subset, 3 of the patients with asthma or bronchitis were also clinically obese.
Yes, it's a really important nuance. Obesity raises your baseline intra-abdominal pressure just by itself. So when you layer those acute violent cough spikes on top of a heavy baseline load, it's just a compounded biomechanical disaster. The surgical anchors don't stand a chance.
Okay, so knowing this, knowing that a chronic cough is essentially this biological wrecking ball, how do surgeons even handle this? Like, this raises an important question about surgical choice. If you have a severe COPD patient who desperately needs an SUI repair, what do you do?
Well, the sources show there's a fierce debate about this. Because theoretically, if someone is generating massive downward pressure, you want the most robust anchor possible. So a lot of experts suggest a retropubic colposuspension, suspension, like the Birch procedure.
Because that anchors into the Cooper's ligament, right?
Right.
Which is super rigid.
Exactly. You anchor the fascia to the ligament instead of just relying on the softer endopelvic fascia. It's theoretically stronger against shear forces.
But here's where it gets really interesting in the sources. Because there's this huge contradiction. The texts explicitly say that despite that mechanical logic, a lot of surgeons actually prefer to use primary pubovaginal slings for these patients.
Yeah, they do. And their logic is that a sling acts more like a hammock. It distributes the force of a cough over a much wider surface area under the urethra, rather than point-loading all that kinetic energy onto just a few stitches at the Cooper's ligament.
Which makes sense as an engineering concept, but, and the sources make a point to hammer this home, there is literally zero hard data to prove that slings are actually better in this scenario.
None at all. It's a perfect example of clinical intuition, trying to outsmart the mechanics without definitive outcome data to back it up.
So they were kind of just flying blind, hoping the hammock holds.
Pretty much. But, to be fair, the data isn't entirely doom and gloom. It's not a guarantee that a COPD patient will fail. The Tegerstedt study from 2001 is a great counterweight here.
Oh, right, the long-term one. What did they find again?
They tracked over 160 women who had an abdominal colposuspension for anywhere from 5 to 11 years. And they actually found that having a chronic disease like bronchial asthma was not always associated with a lack of continence long-term.
Wait, really? So they held up?
Some of them, yeah. The risk is incredibly high, But if the patient can just make it through that initial acute healing window without tearing the repair, if they can get that tissue to integrate, the long-term survival of the surgery is actually possible.
Wow. Okay, so preoperative counseling is just massively important there. You have to tell the patient, like, hey, this is fragile right now. Do not push it.
Exactly. It's all about managing that early healing phase. Which actually brings us to a really terrifying point in the sources. We talk a lot about long-term wear and tear, but the absolute greatest danger to the surgical repair might actually happen before the patient even leaves the operating room.
Are you talking about extubation? When they take the breathing tube out?
Yes, the immediate perioperative threat. When a patient is under general anesthesia, they have a tube in their airway. As they wake up, that tube has to come out. But the trachea is incredibly sensitive. So as the anesthetic wears off, the body feels this foreign object and triggers a massive violent reflex to cough it out.
They call it bucking on the tube, right?
Exactly. Bucking.
Yeah.
It's a series of severe, spasmodic, completely involuntary coughing fits. And remember, this is happening maybe 10 minutes after the surgeon just placed those delicate sutures into the fascia.
Oh, that is a nightmare. The tissue hasn't even had an hour to heal, let alone weeks.
Right. And the patient is still half asleep, neurologically disorganized, so they can't even brace their pelvic floor. That bucking generates this explosive spike in pressure that slams straight into the fresh repair. You can instantly stretch the fascia or completely rip the sutures out like cheese wire. The surgery is ruined before they even wake up.
So you do this flawless anatomical repair, and the body's own airway reflex just destroys it in 5 seconds. That is wild. But the sources talk about a way to stop this, right? Some kind of anesthesia trick.
Yeah, they detail a pharmacological fix. There's a meta-analysis by Sakai in the literature that looked at using topical airway anesthesia. Basically, they just spray something like lidocaine directly onto the airway mucosa before intubation or right before taking the tube out.
Just to numb the area so it doesn't trigger the cough.
Exactly. Numb the mechanoreceptors. And the data is highly compelling. They found a 45% reduction in coughing during wake-up. And they calculated an NNT, a number needed to treat, of 4.61.
Okay, remind me, an NNT of 4.61, that's really good, right?
It's phenomenal for a perioperative intervention. It means for every 4 or 5 patients you treat with a cheap, simple lidocaine spray, you completely prevent one instance of severe, potentially surgery-destroying bucking.
Wow. Okay, so that's the OR sorted. But eventually, the patient has to go home, and if they have COPD, they are going to cough. What can they actually do to protect themselves once they are back in their living room?
That's where we move from anesthesia to behavioral modification. And the guidelines introduce this concept called the knack.
The knack. It sounds like a magic trick.
It kind of is, mechanically speaking. It's a volitional motor control strategy. Basically, the physical therapist trains the patient to do a really fast maximum contraction of their pelvic floor muscles in the exact milliseconds right before and during a cough or a sneeze.
Okay, so how is that different from just, doing Kegels?
Kegels are more about building baseline strength over months. The knack is purely about timing. It's a preemptive strike. You feel a cough coming, you clamp down on the pelvic floor, and you hold it tight while you cough. You are actively bracing the hammock yourself.
Manually stiffening the backboard.
Exactly. And the data on this is incredible. Peschers and colleagues did this ultrasound study where they physically measured the pelvic floor moving during a cough.
So they could actually see what the bladder neck was doing in real time.
Yeah, real-time kinetic imaging. When a woman coughed normally without bracing, the pressure physically shoved the bladder neck down by an average of 8.1 millimeters.
8.1 millimeters, that's a lot of stretching on a fresh surgical anchor.
It is. But when that exact same patient used the knack, when they squeezed right before the cough, that downward mobility was cut down to just 4.7 millimeters.
4.7, that's almost half.
Nearly cut in half. Just from timing a muscle contraction correctly. You are actively defending your own surgical repair from extreme stretching. The guidelines push this super hard, not just for coughing, but for lifting, bending, anything that spikes abdominal pressure.
So what does this all mean for you as a clinician or a patient? Treating SUI obviously isn't just about the pelvic anatomy. Like, you can't just focus on the surgical knot. You have to treat the whole patient, and especially their lungs.
Yeah. If you ignore the lungs, you are fighting a losing biomechanical battle, which is why the sources are so strict about this. Aggressive management of airway disease and absolute smoking cessation are essentially non-negotiable before these surgeries. You have to lower the pressure spikes in the chest to save the pelvis.
Which brings up a final kind of provocative thought for everyone listening to mull over. We know chronic coughing destroys these repairs, but right now globally we are seeing this massive rise in respiratory issues, right?
Oh, absolutely. Between urban air pollution, wildfire smoke becoming this seasonal norm for huge populations, and the long-term effects of recent respiratory viruses, chronic coughing is becoming so much more prevalent. The baseline respiratory health of the average patient is deteriorating.
Right, so the biomechanical stress tests on these pelvic surgeries are just going to keep getting harder. Does this mean the pelvic surgeons of the future are basically going to have to become quasi-pulmonologists?
They might have to. If they don't aggressively screen and optimize these airway issues long before they ever make an incision, they might just watch their surgical success rates completely plummet.
Because it all comes back to that mooring line on the dock. You can be the most skilled surgeon, tying the most intricate, mechanically perfect knot in the world. But if you don't check the weather forecast and you ignore the storm building in your patient's chest, it's just going to tear the whole thing apart. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking for those unexpected connections in your own health or clinical practice, and we will catch you on the next deep dive.